Welcome, everybody. Welcome to another episode of PEM Rules, the Pediatric Emergency Medicine podcast. I'm your host, Yaron Ivan, as usual. And today, again, more important rules that hopefully will help you take care of your patients. Rule number 144. Make a decision and move on. This is probably one of the most important aspects of our role as emergency providers. You gotta make a decision about what you will do next. And sometimes making that decision is very difficult, and it's a very difficult step to take. A great example is the decision to intubate a patient. Probably one of the most invasive procedures we do as pediatric emergency providers, something that condemns the child to being ventilated, being in the ICU, prolonged admission, etc. Certainly not a benign situation. That often makes it a very difficult decision. For example, if I see a child with severe bronchiolitis, I suction, I put them on high flow, and they're still working hard to breathe with significant respiratory distress. Yes, there's a chance that in a minute or 2 or 3 or 10, the child would improve after being on high flow for just a little bit more time. Yes, of course, there's a chance that if we suction him or her again, they will get better. It's a very difficult decision. Do I need to intubate this patient, or can we just wait a little bit more? Under those circumstances, I try to talk myself out of delaying the decision and just make a decision. It's probably better for the patient to be intubated and be intubated early than for me to contemplate the decision and contemplate the situation, delay intubation that will possibly have certain bad outcomes. One of the advice I got as a pediatric resident in the ICU, make a decision. Decide what you're going to do and follow through. Most times, thinking about it for too long or delaying your decision making and just simply looking at the patient, hoping things will get better on their own, is not the right thing. This rule also has to do with leading by example and being an assertive leader who moves on, makes decisions fast, and is efficient with his care. So remember, rule number 144, make a decision and move on. Again, sometimes easier said than done. Rule number 145, address the bacteremia. This rule relates to any time you obtain a blood culture. The way I see it, and some doctors may disagree, getting a blood culture basically translates to you are worried that this patient may be bacteremic, since that is the reason you're actually obtaining a blood culture. I think under those circumstances, you must address the actual possibility that this child is actually bacteremic. It makes no sense to me to test for a medical emergency such as bacteremia and not treat it empirically. So my advice to the residents that I work with is always to obtain a blood culture if you truly worry the child is bacteremic, but if you obtain the blood culture, reflex it with antibiotics immediately. Usually ceftriaxone is sufficient, covers the child for 24 hours. You can even send the child home if the vital signs look okay, knowing that he or she are covered even if they have bacteremia. I do the exact same thing and teach the residents to do the exact same thing anytime they work up a newborn patient with a fever and obtain HSV PCR in the CSF, or even HSV culture, which we don't really use anymore. HSV meningitis in the newborn is a medical emergency, and waiting for the test results to actually treat the child makes no sense to me. HSV PCR takes a few hours, HSV culture takes a day or two, and since you will not have the answer whether the child really has HSV meningitis, better to treat it empirically, admit the child, and let the hospitalist take it from there. So remember rule number 145, address the bacteremia. If you're obtaining a blood culture, treat it until you know better. Rule number 146, go with your gut. This is especially true when thinking about diagnostic tests or working up a patient in the pediatric emergency department. Many times I work with the resident who presents a patient with abdominal pain, and I can tell from their presentation that they're not particularly worried about a surgical abdomen or anything serious. They emphasize how the child can jump. They emphasize that he or she do not have a peritoneal signs. And then in the differential diagnosis, they may include surgical abdomen, and they offer or suggest that we work him or her up. Oftentimes, I feel like if the history is not concerning for surgical abdomen, which the resident just told me it isn't, as well as the physical exam, the suggestion to work the patient up for surgical abdomen doesn't come from a gut feeling, rather from a protective medicine aspect, or maybe just trying to impress me and trying to take a conservative approach for no great reason. Under those circumstances, I ask the resident to pause for a second and think about the case again. Oftentimes, when I say something, what does your gut tell you? Does your gut tell you, does your gut feeling tell you that this child has a surgical abdomen, or is he or she okay? When I often present that question, many times I get the answer of, Dr. Ivan, I actually think you're right. I don't think this child is a surgical abdomen, and I don't think he or she need the workup for it. I find that by helping them pause for a second and rethink the situation and pointing them at their first initial instincts or their gut feeling helps them reframe the situation and make a better decision. Generally speaking, I think it's a bad idea for us physicians to make decisions based on protective medicine or any other aspect that affect the child's care other than her or his medical needs. Another good example is the patient that presents with a fever. Very often, patients with fever, the resident would suggest or recommend some workup, namely CBC or urine analysis or chest x-ray, which I never really oppose, but again, oftentimes when they present the patient and I say, what does your gut feeling tell you? Do you think this child has a viral illness, or do you think we're actually going to find pneumonia or UTI today? Again, when I say that, sometimes I help the resident reframe the situation and go with his or her gut, saying more confidently this child probably has a virus, he or she are probably okay, and can be discharged safely and follow up with the primary care. So remember, rule number 146, go with your gut. Most of the time, you won't find yourself wrong. And that is it for today, guys. Thank you very much for listening, and thank you for supporting PEM Rules. I appreciate it. Let's review what we learned. Rule number 144, make a decision and move on. Again, sometimes easier said than done, but oftentimes it's better to make a decision, go with that decision, rather than staring at the patient, contemplating, and possibly having a worse outcome. Rule number 145, address the bacteremia. Obtaining a blood culture basically translates to you are worried this patient is bacteremic, and since test results for bacteremia, namely a blood culture, do not come back for 24 hours, and bacteremia is a medical emergency, better to address it now with a dose of antibiotics and maybe even admit the patient as opposed to getting the blood culture without doing anything else. Rule number 146, go with your gut. After your history, physical exam, and if you are a trainee and presenting the patient to your supervising physician, go with your gut. Yes, you can work up the patients, you can get CTs and blood tests, etc., but oftentimes your gut feeling is what you should go with. Try to avoid making decisions based on impressing the attending physician or just checking for the sake of being safe. Remember rule number 146, go with your gut feeling. The following outro is one of my favorite songs from the 90s, back when I was a teenager. This is Creep by Radiohead. Hope you like it. Thanks again for listening. Have a great day.